Hello and welcome to this episode of Dr. K's Psychobabble, and took a break for a while from doing these videos, and I'm actually doing this video in response to a comment that was left on my video for agoraphobia. And this is in no way meant to be, a tit for tat sort of back and forth. I learned quite a bit from Mercury XYZ. I'm going to refer to you as Mr. Quicksilver. Might be Mrs. Quicksilver. I don't know. But either way, the response was intriguing, and I thought that we'd revisit the idea of agoraphobia and kind of go through some of what you might pick up on Mercury's comment and my response to that, and then some additional information that Mercury has left for us to consider. So I'm going to piece it apart what Mercury did, and let's take a look at that. First and foremost, Mercury referred to as that most psychologists always referring to the manual, and what Mercury is talking about is, of course, the Diagnostic and Statistical Manual of Mental Health Disorders, the presumed Bible for mental health disorders. It is a book that is put out by the American Psychiatric Association, gathering together information on disorders and cataloging them in a way that individuals can then have a language to describe what they're observing in the community in terms of problematic issues that come up. This is good for treatment, it's good for research, and it's good for understanding clusters of behavior. And that's what I want to point out, is the utility of the DSM, then we'll talk about its limitations. Now, in the title, we often refer to it as the DSM-5. It's in its 5th edition, but the title's DSM is Diagnostic Statistical Manual. It's important to understand what this is: a manual with errors, not always 100% accurate. That's beyond the scope of any effort like this. But the true purpose of the manual is to recognize that sometimes symptoms, for whatever it is that's going on, will cluster together. They appear often together statistically, and we can group those together, and we can give them a name that's characterized of each one of these collections. And there's our diagnosis number 1, is when these things sort of group together. And the diagnostic criteria is usually a list of these symptoms that tend to group together, and the frequency, duration, and impact of those are rated in a way as the person, do they actually have the diagnosis or not? Now, in addition to that, there might be others, of course, other symptoms that individuals have. And there might be another cluster. And notice how these cross over. There might be symptoms in multiple diagnoses. This gives our diagnosis number 2. And this allows us to categorize what might be going on with an individual. Now, these are linked to research on treatments, whether those treatments are medical, whether they're psychological. It's a language that allows individuals to say, yeah, that's what I'm talking about. Now, this book has been fraught with controversy. It's undergone revisions. Homosexuality used to be a diagnosis in there. We know that there's aspects of it that have changed because the society's values about what is normal and abnormal have changed. And this is a working document. Useful, however, because it gives us a language so that when we're talking about something, that is what we mean. Now, in the video for agoraphobia, we can look at the particular aspects of agoraphobia from the point of view of the DSM and what is out there in terms of treatments for individuals who have that cluster of problems. Now, I'm going to throw out some things that are going to come out a little bit later in this video, And that includes that it's pretty necessary to understand that an individual gains a diagnosis because that individual or their loved ones have approached a professional in the field and have said there's something going on with this person, or the individual goes, I'm uncomfortable. It's whatever this thing is that's going on, it's interfering with my life. And I want to know what that is. And the response of the professional is to investigate the symptomology, the duration, their impact, look for those clusters. It's actually pretty rare that someone comes in their textbook. Usually it's sort of like, it might be this, it might be that. Might have to experiment with treatment in order to see which one it is, kind of thing. It's an art as much as it is a science. And so I'm not professing that the DSM is flawless. I'm not professing that the professionals in the field that use it are flawless, but it's certainly a good starting point when we're having that discussion and someone is distraught with it. That's the important. We have to understand that people approach psychologists or their physician because they're in pain and they want that pain relieved. So this is one mechanism, notwithstanding that if you don't have a diagnosis, it's really difficult to get insurance companies. That's a whole other issue, but it's really difficult to get insurance companies to pay for anything that you're going to do with an individual unless you have a diagnosis attached to it and some evidence-based practice that is attached to that diagnosis. Now, still dissecting Mercury's comment, so let's go to the next comment. Agoraphobia is not a phobia, for one. It's a genetic disorder. It's not psychological. And psychologists are not the individuals who should be treating this. Now let's take a look at each one of these things and understand where they're coming from. The word phobia refers to anything, any thought pattern that an individual has that is irrational. Now this word is getting used a lot. There are phobias that are clear: fear of heights, fear of spiders, arachnophobia. We have agoraphobia. We have all kinds of words associated with that. And we even have an extension of this into the social interactions in the social world when we start talking about things like Islamophobia or homophobia, any one of those things. The key is to not really latch on to the concept of fear of spiders, fear of heights. It's rational in some cases to be afraid of spiders. If it's a brown recluse spider, you probably don't want to make friends with it. If you're on a really, really high tower, or you're mountain climbing, mountain climbers and rock climbers will say it's the fear that keeps them careful when they're doing that. Those are rationals. Those are rational fears. The point is irrational. I mean, it lacks evidence. A person's emotional experiences about a particular situation elicit an emotion, strong, in their words, out of control, out of their personal control, physical response. It's almost like the body is betraying me. They could even be thinking, I had a client who had a fear of heights that disabled her in climbing stairs. It wasn't if she was on an airplane or hanging, doing skydiving. Those would all be rational fears. But she would climb up a set of stairs and she'd be petrified. It's that irrational component to it. When we look at phobias and we look at what's going to be very important in terms of Mercury, what Mercury was writing about, the actual general anxiety topic, when we just look at anxiety itself, that the point is for it to be in this area, it's irrational. Even the individual going through it will comment, regardless, they'll say, there's nothing going on. I just feel like scared, I'm going to die, the typical panic attack, or just very uncomfortable with that individual's experience. So they're expressing that, and we use the phobia. The phobia is, we think about it in the common way as an extreme fear, but the point is it's irrational. So, for example, homophobia, Islamophobia is not supported by evidence, for the general population of those groups. So a fear of them or a distaste or a hatred toward those individuals is irrational. It doesn't make sense looking at the evidence. Now, the next thing that's included here, genetic disorder. You are absolutely right. But what's a disorder? It's genetic because it is very likely that anxiety disorders are a misfiring in the body. The body goes into its fight, flight, fawn type reaction, and we've all had that when somebody is cut in front of us, and that's adaptive. It protects us. It's evolutionarily defined. We're all good with that. The thing that's happening is something that's irrational is bringing that about in terms of the phobias. And for some individuals, and I think this is really what Mercury is talking about, every once in a while that system gets triggered. Depending on the individual, it might get triggered a lot, or it might not, or it might happen every once in a while. And I say triggered, but it just starts. Trigger would imply that something initiated it. Someone could just be sitting there and lapse into an attack, panic attack, or the feeling of that anxiety, or you call it agoraphobia or whatever. Doesn't really matter at this point. You're looking at something that is very, very biological. I'm going to come back again, but what makes it a disorder? It's a disorder when it interferes with our life, when it interferes with function. In psychology, we talk about 3 ways in which we define abnormalness. First, statistically rare, and that's always kind of a dicey one. In times like we're in right now, there's a lot of depression, so depression isn't rare, but usually it's rare, and so that factor, it's rare, so statistically it's rare, hence the name Statistical Manual. The second one is in terms of our cultural norms, the behavior lies outside of those cultural norms. Third, interferes with the functioning in daily life. So the degree to which a person experiences anxiety in that third one is probably going to be the degree to which they approach professionals for help for that. It's usually that idea. There are individuals, as Mercury said, who are able to live relatively normally with the sense of anxiety, whether it's agoraphobia or other kinds of anxiety, because they've learned how to reframe them and control them, and they may carry the diagnosis of an anxiety disorder or whatever, but it's not impacting their life the way it might in some other people. There's some diversity in terms of intensity, and there's some diversity in terms of a person's ability to cope. So the next one that we look at in the statements from Mercury is it's not psychological, and psychologists are not the experts to go at. And this is probably where I take issue. First of all, I believe in holistic approaches to problems. Like whether something is genetic, regardless, I've worked with individuals with genetic disorders such as Down syndrome, cerebral palsy, any one of those are purely genetic, but the results of those genetic disorders, the dysfunction, the fear, the change in life, the expectations, the family members and how they're impacted vocationally, socially, all of those things are a great area for the wealth of effort that psychologists can bring to the table. Psychologists will address the issues of how is this genetic disorder affecting them? How is it affecting their thinking? How is it affecting their actions when they're feeling that way? How is it affecting the people around them if you're working with family and whatnot? While at the same time, there might be a medical intervention going on with medication, or the intervention that Mercury brought to my attention that was, I think, the most valuable part of this whole conversation. So psychologists always play a role because regardless of the origins, psychosocial or whatever, psychosocial or genetic, there's still the emotional, psychological effect that has, and that can be addressed with the expertise of a psychologist. Now, we go on, like I was saying, some need to lead a normal life. That is very true. And here's where I want to make the difference between treatment and rehabilitation. It's a whole other video I have on this. Now, treatment is what would happen for an individual is engaged in activity to lessen the symptoms. That's what treatment does. I have a broken leg. I engage in cast treatment, laying off the weight on that leg treatment, and the symptom, my leg is broken, disappears and my leg is no longer broken. So I move from status, from a person who has a broken leg to a person who no longer has a broken leg. That is a result of treatment. Now, of course, disorders like this, it's not always that clear, but whatever somebody's doing that is specifically engaged in lowering the existence of the symptoms, typically medical approaches, medication, surgery, those kinds of things that doctors do would be the world of treatment. That is to lower the incidence, lower the intensity, remove the symptomology. I contrast this with rehabilitation, although we often throw rehabilitation into the general moniker of treatment. Now, rehabilitation, technically speaking, is to habilitate, means to operate within the world. Rehab means I'm going to return you to your previous level of functioning. It may or may not have anything to do with where the symptoms are. My expertise is in psychiatric rehabilitation. In psychiatric rehabilitation, I'm aware of the degree and intensity of a person's symptomology. My job is to help them function despite that. That's the rehabilitation. But some of that rehabilitation involves changes in their environment. Some of that involves changes in terms of what their family and friends understand about them or their coworkers. Sometimes it's helping the individual to gain practices of self-awareness that allow them to act in ways that keep these symptoms away from interfering or help them reduce the overall impact emotionally of those symptoms. The symptoms can still be there. And this is really leading to the work that Mercury introduced to me. And this is probably one of the coolest things. So the work of the physician might be treatment. The work of the psychologist in the rehabilitation might be to work with the other areas of coping with things. There are psychologists that work on treatments. An individual who's depressed, we can help that individual develop a life plan that may result in some actual relief of symptoms in cooperation with the psychiatrist who might be prescribing medications. But let's look at Claire Weeks. I did not know who this person was when I read this, and I didn't know who this was. And first and foremost, the Mercury said the method of Claire Weeks is the only thing that works. I'm going to take issue with that. There's a lot of diversity, and although Claire Weeks' methodology for dealing with anxiety is a well-known, well-practiced, well-established method for dealing with anxiety disorder, there's a lot of individuality there, and we do leave the door open that for some individuals this might not be the way, but it's certainly one of the most profound current ways in which we deal with anxiety. So here we go. So here's Claire Weeks. She's an Australian, she was an Australian doctor, and she herself had anxiety disorder, and she developed a method for herself and then published on it and became world famous for her method. The method involved essentially 4 steps. Facing the fact that the anxiety, in the presence of the anxiety itself, the patient, for lack of better terms, faces that this is something physiological going on with them. And it's separate from the circumstances that are happening around them. Again, removing it from that irrational thought process that something really is threatening you, and therefore making it just physiological. Second step is to accept that that's going on, that you're still okay, that you give yourself permission to be able to make it through this particular episode. And that initiates the process that we refer to as floating. And this was almost a purposeful depersonalization from it. And that the individual can then, within their own mind, practice. This occurs over time, obviously, to get good at it. Practices that there's my anxiety and here's me. And then I'm going to ride it out. That's the time. You give it time. So with my understanding and acceptance of this is physiological. This is one of those physiological things like hiccups. Here it is. I got to just let it be, float. I'm different. I'm separated from this. I don't need to respond to it. I just need to be in a safe place and just give me some time, and it's going to go away, and I can make my way through the session. She introduced this, and this was revolutionary. And I'm really, really appreciative of the fact that this got brought to my attention. I didn't work a lot in anxiety disorders, and so I was mostly working with the major mental illnesses, of which anxiety is one, but not this. I've become a fan. This is really, really cool stuff. I've integrated it into some of my classes. And it's a very cool part of doing what I'm doing here is hearing from I'm going to say a fan, and that there's this stuff out there that's big and I didn't even know about it. I am going to say, however, I cannot think of a better representation of cognitive behavior therapy than this. Essentially, cognitive behavior therapy is a psychological treatment modality, treatment and rehabilitation, that does just this. Facing the physiological thing that's happening, whether it's depression, anxiety, worries, whatever the individual has faced, that there are physiological parts to this, and that you are not in control of those. You focus on the things that you are in control of. You accept that, and the floating becomes either in this case, a sense of waiting for this to happen, separating from the anxiety and waiting for it to happen, or a scripted alternative behavior that a person will engage in that they've worked out in psychotherapy. And then they engage in that behavior. The engagement of floating and letting time pass deals with the anxiety very effectively, as Claire Weeks promoted. But at the same time, we can also use that same cognitive behavioral component. The actual focus of the behavioral intervention is your thought process. Claire Weeks' methodology is all about thought process. The most qualified individuals to do this would be psychologists. We deal with thought processes all the time and the impact that they can have on our bodies. So, in the end, I thought this is a really great response. Nice big paragraph of response. I love getting that. I hope that Mercury doesn't feel that I've been offended or anything. I love getting that feedback. This is the second time, so I've only been doing this for a while, that I've gotten that kind of, challenge to what I had written, and it just keeps me on my toes. I do the same thing in my classes when students want to call me out and make me think more. I just benefit more, and I hope that they do as well. So I thank you very much for taking the time to respond. I hope this has been clarifying and illuminating for many other people who might be watching this video, and I really appreciate spending some time with all of you examining this particular issue. So I wish you well and take much care.